Hello, everyone, and welcome to today's webinar, Fighting the COVID-19 Pandemic Through Mass Testing. My name is Monir Ragas. I am the Scientific Manager of the EMEA Market at Beekman Coulter, and today I'm excited to be hosting this session. I'm pleased to introduce today's speaker, Dr. Shireen Atif, a consultant clinical pathologist at the National Reference Lab in Abu Dhabi, United Arab Emirates, and a medical director of Imperial College London Diabetic Center Lab. Dr. Atif holds a Doctor of Medicine and Master degree in Clinical and Molecular Pathology from University in Cairo, and she received her diploma in the Clinical Quality Management for Healthcare Reform from the American University in Cairo, and passed a certificate course in Lab Quality Management at the University of British Columbia in Canada. She is the author of 2 books on guidance to lab tests and has many research publications that she presented at different regional and international conferences. Dr. Atif also engaged as a peer reviewer of medical journals like the Arab Journal of Gastroenterology and the Journal of US-China Medical Science. Dr. Atif is a member of many scientific organizations such as the American Association of Clinical Chemistry, Association for Professional Infection Controls, and the Egyptian Society of Lab Medicine. Today, she is going to review the available molecular and serological tests used in the management of COVID-19 and to share with us a summary of all COVID-19 testing guidelines in the UAE, as well as the role of fast and accurate antigen testing in the fight against this pandemic. We will have a Q&A session at the end, so please feel free to take your question at the box in your panel, and we will bring it up later. So without any further ado, I would like to kick things off by welcoming our speaker. Over to you, Dr. Shireen.
Thank you, Munir, so much for your kind introduction. Good afternoon, ladies and gentlemen. It's my pleasure to be with you today. My name is Shireen Atif, and during the following 1 hour, or actually 45 minutes, we will discuss together the technical aspects of different laboratory tests used for the diagnosis of COVID-19 and how we can use these tests in fighting the COVID-19 pandemic. This is a brief summary of the main topic that we are going to discuss today. We will start by brief introduction about the virology of the SARS-CoV-2. Then we will discuss the serology testing used for the diagnosis and monitor the COVID-19 infection. And finally, we will go through the role of the antigen testing in the fight against COVID-19. Since the discovery of the first case of COVID-19 in Wuhan, China, exactly in 17th of November 2019, there are more than 59 million people infected all over the world. 81% of infected people are usually show mild or moderate symptoms, or they are completely asymptomatic. 14% only of the infected people show severe symptoms, severe respiratory or other symptoms, and only 5% of the infected people require admission to ICU and incubation. Unfortunately, till now, 1.4 million people have died worldwide because of the COVID-19, and the number is still increasing. Actually, the SARS virus that causes the COVID-19 spreads very easily between people, and the information from the ongoing pandemic suggests that this virus is spreading more efficiently than influenza virus. Badly, older people and those with underlying medical problems such like diabetes, obesity, and hypertension are more likely to develop serious illness than others. So before discussing the technical aspects of laboratory tests used in the diagnosis of COVID-19, let me first briefly introducing some aspects about this newly virus. So coronavirus belongs to of the coronaviridi, and there are 4 genus of coronavirus. The first is alpha coronavirus, second is beta coronavirus, third is gamma, and fourth is delta coronavirus. The alpha and beta genera are all the human coronavirus, and they include 7 viruses that cause disease to human. And actually, coronavirus is not new to humanity. Since coronavirus disease, COVID-19, is the 3rd pandemic caused by coronavirus following SARS in 2003 and MERS in 2012. But actually, both of them were classified as outbreaks with a small number of deaths compared to a global pandemic caused by COVID-19, which causes more than 50 million infections worldwide. Like other coronaviruses, SARS-CoV-2 causes respiratory and gastrointestinal symptoms leading to a variable degree of clinical manifestation. There are different antigenic targets on the surface of the COVID-19, and actually the word corona came from the Latin word means crown. And this is because this virus has a spike protein on its surface, and when you look to it under the microscope, it looks like a crown. In addition to this spike protein, there is another antigenic target on the surface of the virus. Some of them are structural antigen and the other are functional antigen. And it's very important here to mention that the S or the spikes proteins has specific domains called the receptor binding domains, which play a very important role in binding of the virus to the host cells and facilitates its entry inside the host cell. We will speak about this part in details in the following slides. Now, after these brief biological introductions, we can start by discussing different tests used for the diagnosis of COVID-19. And the first question will be, what do diagnostic tests for COVID-19 detect? If you want to detect the virus, so we have 2 tests, either viral RNA detection by nucleic acid amplifications technique or detection of viral antigen. Or you can detect the body immune response against the virus. So in this case, you will not detect the virus itself, but you will detect your immune response against infection with this virus by detection of antibody against COVID-19. Different antibody are developed against COVID-19, immunoglobulin M, G, and I. Molecular methods are the preferred method. It is till now the gold standard for the diagnosis of COVID-19. Target combinations of different genes, either nucleocapsid, ORF, envelope gene, or RNA-dependent RNA polymerase gene. It can be performed on either upper or lower respiratory tract samples, so you can use oropharyngeal swab, nasopharyngeal swab, sputum. All of them can be used as a sample to perform the molecular testing. However, it has many challenges associated with the collection and reagent supply chain, especially during early stage of the pandemic. On the other hand, the antigen detection detects the nucleocapsid antigen, which is the most abundant viral protein present with the viruses, and we can use either nasal or nasopharyngeal swab. The most important feature, the most important advantage of the antigen test, it's fast, the short turnaround time. It takes about 15 minutes. It could be lateral flow immunofluorescence assays or as a point of care testing, or it can be lab-based test as a wave test. It is very specific, but unfortunately, the sensitivity is a little bit low, and negative results should be confirmed by molecular assay. So according to the WHO, the confirmed case is a person with laboratory confirmations of COVID-19 infection, irrespective of clinical sign and symptom. And this diagnosis actually putting the lab and the laboratory medicine in the very core of this diagnosis. The routine confirmation of the case of COVID-19 shall be based on detection of unique sequences of virus RNA by nucleic acid amplification, not limited only to RT-PCRs. We can use the nucleic acid amplification technique, others nucleic acid amplification technique. The most commonly used is RT-PCR. And of course, the use of 2 genes target is a worldwide recommendation. The International Federation of Clinical Chemistry recommended the key clinical indications for molecular testing to be as following. To diagnose viral infection in acute phase of symptomatic illness, less than 14 days of infection, and at that time, maybe the antibody will not be developed, and molecular and antigen test will be the only way for diagnosis of SARS-CoV-2 infected. Sorry. To assess in clinical assessment of asymptomatic, pre-symptomatic, or mildly asymptomatic patients with non-exposure to positive COVID-19 cases, and also to assess in screening of asymptomatic, pre-symptomatic, or mildly symptomatic individual in various contexts, including but not limited to before scheduling surgery, delivery, travel, hospital discharge, return to work or school, and to manage small outbreaks. There is currently insufficient evidence to suggest a definitive advantage of selecting an assay based on a specific gene target. So we can use any gene target. There is no specific recommendations to use any of them, but the assay for molecular diagnosis should employ a minimum of 2 gene targets to minimize the risk of false negative results. Speaking about serological testing, as you know now, is becoming extremely popular, and many assays developed right now to detect the COVID antibodies. So, as you know, the immune response is very important for those infected with COVID-19, and of course, the hope is to use this immune response in the futures with the development of vaccine. This graph actually showing the immune response to the COVID-19 when the virus is infecting the cells is normally uses a protein called spike protein, which known to bind the receptors called angiotensin converting enzyme 2 receptor or ACE2 receptors. And interactions with the virus of these receptors with the virus allow it to enter the host cells. When the virus enters the host cells, it triggers replications and amplifications. The virus is then recognized rapidly by the immune system, and the first cells that will recognize the virus are called the antigen-presenting cells, which interact and trigger the T helper cells. T helper cells is very important in the immune response because it stimulates the beta cell to differentiate to either memory beta cells or plasma cells, and the plasma cells is the cell that will be responsible for the production of antibody against COVID-19 and neutralizing the effect of this virus. I know that many of you are familiar with this graph that's showing the course of molecular and serological biomarkers. So current evidence indicates that SARS-CoV-2 antibody begin to develop approximately 6 to 10 days after infection with SARS-CoV-2. The IgM appears after 12 days of infection and persist in a sufficient amount for about 35 days, and after that it is decreased rapidly. While IgG, which represent mainly the main immune response against COVID-19, observed to peak approximately 17 days after SARS-CoV-2 infection and persist for a longer time, at least 49 days. And there are variable assay types available in the market for serological tests, starting by point-of-care testing or lateral flow, which are very rapid, but they are only a qualitative assay. Then we have the automated platform or the laboratory-based testing, mainly chemiluminescence immunoassay and ELISA. And finally, we have the neutralization assay. Neutralization assay is a specific type of assay in which the plaque reductions neutralizations test is performed. These tests require a biological safety cabinet level 3 and live virus, and it measures the neutralizing antibody or used as a confirmatory test. The plaque reduction neutralizations assay evaluate the ability of the patient's serum, which should contain the antibody against COVID-19 to prevent live virus from infecting susceptible host cell. So the serum of the patients are titrated and results are determined at the highest dilution that prevent 50% of 90% of viral plaques. Because culturing the SARS-CoV-2 require biological safety cabinet level 3, the lab infrastructures assay have been only limited to certain laboratory, and also it has developed using pseudovirus. These pseudovirus require only biosafety cabinet level 2. The available assays also show variability regarding immunoglobulin class. So some of the assays detect IgM, others detect IgG, fewer are developed to detect IgA, and some detecting the total antibody. And here we should remember that the CDC COVID-19 guidelines published on May 2020 stated that there is no advantage testing for IgG, IgM, or total, and testing for IgA is not recommended. It has a minimum clinical application. The others classification actually based according to the antigenic target. This antibody directed to which antigen on the surface of the COVID-19. So we have some antibody or antibody that can detect the S or the spike protein, either S1 or S1 plus S2 or the receptor binding domain, or antibody that can detect the nucleocapsid antigen, which is the most abundant viral protein. Speaking about the spike protein, so although coronaviruses uses many different proteins to replicate and invade the cell, studies have shown that the S proteins play the most important role in the viral attachment, fusion, and entry. The spike protein utilized the angiotensin converting enzyme receptor for cell entry, and these receptors is present in a different tissue, not only in respiratory or alveolar epithelial cells, but they are also present in lymphocytes and extrapulmonary tissue like heart and kidney. So the existence of antibody against these receptors or against the S part of SARS-CoV-2 may suggest neutralizations of SARS-CoV-2 infection. And to prove that or to assess that, an elegant study actually performed using pseudovirus particles-based neutralization assay and found that there was a significantly positive correlation in neutralizing antibody titers between the pseudovirus and COVID-2. They also demonstrated that the most recently discharged patients has strong humoral immunity to SARS-CoV-2. Maybe the level of antibodies start to decline after that, but just after infection, just after discharge, the level of humoral immunity will be detected and it will be high. In another study also published in Cell Reports Medicines regarding the correlations between the neutralizing antibody and the anti-S1 receptors binding domain immunoglobulin assay, the authors actually did a cross-sectional study of hospitalized COVID-19 patients They suggest correlations between the SARS-CoV-2 receptors binding domain, IgG response, and virus neutralizing antibody. And these findings have applications for understanding the immunity and development of vaccine. The coronavirus or the spike proteins maintain entry to the host by attaching to the angiotensin converting enzyme 2, and the neutralizing antibody are important to understand the therapeutic use of immune plasma. And we found that in SARS-CoV-1 vaccine and SARS-CoV-2 vaccines, the protein interacts with the receptor's angiotensin converting enzyme. And we found that actually in a few numbers of SARS-CoV-1 vaccines that meet to phase 1 clinical trial before funding dried up when the vaccines are eradicated and the virus stopped transferred between human beings. And in both cases, we found that the protein interacts with the receptor angiotensin converting enzymes and antibodies targeting the spike interfering with the binding. Thereby, they can use as neutralizing antibody or they can neutralize the virus. That's why the spike protein is disclosed as a target antigen for at least 7 out of 14 clinical vaccine candidates and 50 out of 133 preclinical vaccine candidates. This is actually a very important question. Which SARS-CoV-2 serology test should I use? When I should use the total or IgG SARS-CoV-2, and when I should use the SARS-CoV-2 anti-S or antibody directed to the S domain. So actually the answer is depending according to the situations where we want to use these tests. If you want to do a seroconversion study or a seroprevalence study, the best is to use the anti-SARS-CoV-2. For determination of antibody positivity, to check the immunity as a screening of high-risk population, also we recommend to use the total antibody or SARS-CoV-IgG. To add to the molecular diagnosis or to complement the nucleic acid amplification technique, we can use also the anti-SARS-CoV-2 antibody. In cases of checking the vaccine immunity or response to vaccine, effectiveness of the vaccines, and checking the level of the antibody in plasmapheresis for plasma donations, the best antibody to use is the anti-SARS-CoV-2 anti-S antibody. And of course, both of them can be used to increase the sensitivity for S or N only responders. A lot of guidelines have been issued about the use of the serology testing and how to implement it in the clinical field, starting by the CDC Guidelines, which issued the interim guidelines for the COVID-19 antibody testing, and the International Federation's interim guidelines on serological testing of antibody against SARS-CoV-2. And in addition to that, we have our own guidelines that has been released by the National Crisis and Emergency Authority, or NCEMA. NCEMA actually issued the first national interim guideline for the use of the antibody or serology test. UAE was the first country in the region to develop these national guidelines, and I am honored to be part of this working group. This is amazing working group that includes a lot of physicians and consultants from all over Emirates. So all the guidelines, actually the global guidelines, stated that the benefits of the serology test will be mainly for antibody detection, especially with PCR to complement the PCR. We can use IgM to detect the immune response with PCR provided more complete clinical picture. For prevalence study, serological testing may add to identify individuals with immune response to SARS-CoV-2. For selections of plasma donors for convalescent plasma, and also to identify the immunity status and to know if the person infected with coronavirus has already developed antibody against the virus or not. We also stated that the interpretation of the result for the antibody should be done with cautious. So negative result means likely there is no previous infection or exposure to the virus, while positive results suggest recent or past infection. These results don't tell us when the patient was infected, it is just an old or past infection, where they are shedding the virus or not, if the virus is live or dead, and where patient or individual are protecting against reinfection. And this is the main question right now. If these antibody are immunizing antibody and how long this immunity will last. And this is an example of reporting comment at Mayo Clinic. So positive results means that SARS-CoV-2 immunoglobulin antibody detected. Results suggest recent or previous infection with SARS-CoV-2 and correlation with epidemiological risk factor and other clinical laboratory finding is recommended. While negative results mean there is no immunoglobulin antibody to SARS-CoV-2, and negative result may occur in serum collected too soon following infection or immunocompromised or immunosuppressed patients, because if it is collected very early, the time will not be enough for the antibody to develop, and the immunocompromised patient will not be able to develop. Also, all the guidelines recommend and give recommendations for 3 strategies to improve the positive predictive value. The first is to choose a test with a very high specificity, mainly 99.5% or greater, and to choose the population on which you will perform the test. So the test persons with history of COVID-19 like illness who have a high pre-test history or having SARS-CoV-2 antibody. Another strategy also is to implement an orthogonal testing algorithm in which the person who tests positive are tested with the second test, and it is preferably to be detecting other antigenic epitopes. So for example, if you make the test first times with to detect antibody against N, next time of the second test is better to use to detect antibody against S. What about the SARS-CoV-2 antigen test, which is the last version of the diagnostic test added to the market right now? So actually, the use of the antigenic test for diagnosing viral infection have been used since long time. We used to diagnose other respiratory pathogens using antigen tests like respiratory syncytial virus and influenza virus. And also the CDC recommends the use of the rapid antigen test for influenza, primarily to inform decisions on treatment and also to direct infection control actions at that time. The antigen test directly detects a fragment of SARS-CoV-2 virus protein. The main advantage of the antigen test are its fast turnaround time. It's very fast. The speed is very the speed of the antigen test. It's main advantage. It's simple to perform identifications of current virus and of course lower cost when compared to molecular testing. However, it may not detect all active infection as they don't operate the same way like PCR. So antigen tests are very specific for the virus, but they are not sensitive as molecular tests. So positive results in symptomatic individuals are likely to reflect active infection, but negative results are considered as presumptive negative and should be confirmed by PCR. The antigen tests are authorized by the Food and Drug Administration for the use of symptomatic individual only, and no antigen test has yet been authorized by FDA for the use in asymptomatic individuals. And these figures actually showing the main difference between the molecular test and the antigen test for the diagnosis of COVID-19 regarding sampling collection. So we can use swab for molecular testing, while we can use swab or saliva. The turnaround time is very fast with the antigen test. It takes a few days with molecular testing. Cost, of course, is lower when we are using the COVID-19 antigen test compared to molecular test. The following are different scenarios in which SARS-CoV-2 antigen test may help in diagnosis of COVID-19. Symptomatic patients with an appropriate window for a given test and in a setting with high rates of transmissions. In that cases, in high prevalence situations, this test is diagnostic. If the patient has the symptoms and the COVID antigen test is positive, so it is diagnostic of COVID-19. The most important usage of the COVID antigen test is actually for rapidly triage patients in emergency department. So in emergency department, especially in a hospital setting, when you have a lot of patients complaining of upper respiratory tract symptoms, and you need to do early triage of those patients to separate them in order not to infect the others, this test is also highly recommended. Serial testing and outbreaks investigations in a specific living setting with confirmed cases such as certain facility, long-term care facility, particularly when PCR testing is limited or turnaround time is prolonged, we can use at this condition also the COVID-19 antigen test. In remote populations, and if antigen tests are used for asymptomatic testing, which is still not approved by FDA, repeat testing at set intervals can alleviate the lower sensitivity of the antigen. So there is a recommendation to repeat the test within 3 to 7 days in order to increase the sensitivity of the test, and in such way we can use it for diagnosis in this setting. In really very nice study discussing the false positives in reverse transcriptions PCR testing for SARS-CoV-2, the authors found that the high false discovery rate that result when the prevalence is low is actually questions about the usefulness of mass testing, as positive test results are more likely to be wrong than the negative test. It's actually a general principle. The positive predictive value and negative predictive value of an assay strongly depend on the prevalence of the condition. So in cases of low prevalence, the most important is to rule out the disease, and you need a test with higher specificity. This means not to produce a high false positive rate in the majority of negative cases. While in high prevalence situations, the most important is to rule in to have a test with a high sensitivity in order not to produce a high false negative rate in a majority of negative population or negative species. These diagrams also show the difference with guidelines that has been issued for the use of laboratory testing for COVID-19, antigen laboratory testing for COVID-19, including the CDC Guidelines published in April 2020 and updated August 2020. the World Health Organization's guidelines published April 2020 and updated in September, and also our local guidelines about the antigen testing and what is the best way of antigen testing. Our local guidelines came in accordance with the local guidelines that this test shall be restricted for triage symptomatic individual with respiratory symptoms in emergency department. The molecular test should be used to confirm negative or presumptive negative cases. Finally, this diagram shows the different potential scenario for antigen testing and how it could be helpful for diagnosis of patients with COVID-19 infection in cases of symptomatic and asymptomatic patient. So in cases of symptomatic patient, antigen test is enough for diagnosis. If it is positive, no confirmatory test needed after that, and the patients will be diagnosed as having COVID-19. But if the result is negative, this result will be considered as presumptive negative, and molecular test should be done as a confirmatory test. While in asymptomatic patients, we should look to the facility from where this patient is coming, if it has outbreak or not. If this facility has an outbreak, so the suggestions here is to repeat the antigen test every 3 to 7 days to increase the sensitivity of the test. If the result turned to be positive, so there is no confirmatory test needed. If it is negative, we will continue on serial testing until no positives for 14 days. But if the facility has no outbreaks, in these cases, if the antigen is positive, especially if low incidence area, consider performing PCR as a confirmatory test. If the PCR is positive, so this initiates the outbreak response. Finally, I would like you to take a home message. Currently, the RT-PCR is a gold standard test used for the diagnosis of COVID-19 infection. However, other assays such as antigen and antibody assay or serological assay can also be used to diagnose COVID-19 cases with fast turnaround time. Antibodies most commonly become detectable 1 to 3 weeks after symptoms, at which time evidence suggests that some degree of immunity for future infection has developed. Currently, there is no identified advantage of assay testing for IgG, IgM, or total antibody. Antigen tests are authorized by FDA for use on a symptomatic individual. No antigen test has yet authorized by the FDA for the use on asymptomatic individual. Thank you so much. I'm ready for any questions if you have.
Excellent. Thank you so much, Dr. Shireen, for this great presentation. It was very informative. I think it's time now to take some questions here. So with the remaining time, I think we still have enough time. So we'll go ahead and take some questions. Of course, if we don't get to any question during today's webinar, we'll make sure that we will follow up afterwards. So we have here the first question says, why some governments are recommending antigen tests in congregate settings if they cannot be used to rule out SARS-CoV-2 infection and should not be used as the rule basis for treatment? Really interesting question.
Oh, you mean, can you repeat that question again, please, Munir? So you mean why we should use it if it is not recommended?
Exactly. They said why some governments are recommending antigen tests in congregate settings if they cannot be used to rule out the infection and should not be used as the sole basis for treatment. So they said why there is a recommendation for this specific test?
Yeah. So actually, this is during pandemic. We should use different strategy to fight this pandemic, and one of these strategies is use different technology, different tests, including antigen testing. And again, it's all about the area where these patients are coming from. In area of high prevalence and patients known to be at high risk, positive result from antigen can be considered confirmatory and no need to do anything else. At that stage, it will be a diagnostic test. But in low prevalence area where the patient is asymptomatic, the result should be confirmed with other molecular tests.
Perfect. Okay, thank you, Dr. Shireen. And we have another question. It says, what is the role of antibody testing in vaccine deployment?
Okay, so antibody tests, especially the antibody against the spike proteins, are very important because they are considered to be correlated to the level of the neutralizing antibody. And of course, it will be helpful to identify the vaccine efficiency. So after taking the vaccine, especially the second dose, we are recommending to monitor the immune response in those patients who have been vaccinated by measuring the level of the antibody. If there is a sufficient level of antibody present in their blood, it means that the vaccine is effective. It can create immune response in your body.
Perfect. We have another question here. It's coming now. It says, what is the protective level of neutralizing antibodies in convalescent plasma donors used to treat COVID-19 patients? There's a lot of debate.
This is really very interesting, important question, but the answer is still now we don't know a cutoff value. So we are looking actually to cutoff value. For example, for hepatitis antibodies, we have a cutoff value. So less than 10, you need to have a booster dose. More than 100, it means you are immune. But still, because the virus is new and still we are learning about the immunity and the immune response of the viruses, we don't have a cutoff value at which we decide if the patient is immune or we can use this plasma for treatment of this patient. But a lot of studies now are working in that, and hopefully we will get this soon.
Sure, absolutely. And before I move to another question, I think Dr. Shireen, if you could turn the camera on so people can see. I think it's
not on. Oh, sorry for that.
Yeah. No problem. So yeah, excellent. So
it's working now or not yet?
Yeah, I think it's turned off again. Maybe try one more time.
Okay.
Yeah, take a second usually. Perfect. Yeah, I can see you now.
Working now?
Yes, I can see you. So
another
question, no problem. Another question says, what is Dr. Shireen's medical opinion regarding the new mRNA vaccine developed by Pfizer? It could really cause autoimmune disease or has the possibility to alter individual DNA sequence or his protein synthesis process. Talking about the new vaccine.
I don't like to speak about certain vaccine, but in general, all the vaccine are still under trial. All the vaccine, either Pfizer's vaccine, the Chinese vaccine, all of them are still under trial. We need time. We need time to know exactly the side effects for each one, to know what is the efficacy or the efficiency of each vaccine. How many years we are using now influenza vaccines, is including all the strains. We need time. But the problem that we are in outbreaks and we are in hurry to develop any vaccines. We will see the response. The clinical trial for Pfizer's vaccine, for the Chinese vaccine, and even for the Russians one are very good. Some of this clinical trial has been performed here in Emirates, and it shows really very good response.
Excellent. Yeah, here another question. Speaking of Emirates, so there is a question about what the strategy of the UAE in using antigen testing. I think this is a very important question.
It has been mentioned actually in our national guidelines developed by NCEMA, and it came in accordance with the global guidelines that the antigen test should be used in diagnosis mainly in symptomatic patients, and should be used for early triage, especially in emergency department. And that's what we are doing right now in a different hospital. They are using these tests. It's a rapid test, point of care testing like influenza testing. They are using it in a fever clinic, in emergency room for early triage of those patients to prevent spreading of infection of COVID-19.
Yeah, but do you think it will be recommended for congregate area, like let's say for the camps, for the labor workshops?
Of course. I think that maybe in the future will be more for serology test, either antibody or antigen, rather than using the molecular test. So molecular test, although it is the gold standard and it is the basic, but still it has some drawbacks. It's very sensitive technique. There is a possibility of false positive result. It's expensive. Also, it needs a lot of time. And in a hospital setting, sometimes you need rapid answer. You need a rapid answer before just scheduling the patient for operations, before delivery, for triage of the patient. So I think with time, we will be more toward the serology test and the use of serological tests for diagnosis.
Absolutely, thank you. Dr. Shireen, being a consultant at the National Reference Lab, would you recommend doing the centralized assay for when it comes to antigen test or antibody test, or would you go with decentralized in doing the point of care? Or just talking about the high volume?
Point of care should be beside the patient, and the point of care testing, it should be the aim of point of care is to perform it as early as possible and to give a rapid result with a rapid turnaround time. So it should be near the patients. But if the condition is not an emergency conditions, and if you have a high through output volume, the test should be performed inside the lab. It should be lab-based test or wave test.
Centralized, yeah. Okay. Okay, wonderful. I think looks like you answered all the questions. Dr. Shireen, thank you so much. It was a pleasure to have you today, and we are running out of time probably, but we're not getting like more questions. So thank you all for taking time out and for being here today. We hope you all have enjoyed this presentation. Please stay safe and have a great day. Thank you.
Thank you so much, Munir. Thank you.
Goodbye.